Say a big thank you to everybody for coming and welcome to the Women's Health Initiative's very first web series. So for those of you who don't know me, my name is Natasha Smith. I'm the Managing Director of the Women's Health Initiative. And the Women's Health Initiative is a not-for-profit organisation that centres the experiences of Black women and women with African, Caribbean and mixed heritage. We strive to reduce the health inequalities and inequities that exist. And we are hoping that we can do our little bit, our contribution to improving Black women's health across the lifespan in terms of their health and well-being. So that's just a little bit about who we are and what we do. And you can find us on Instagram at Women's Health Maternal Wellbeing and our website, womensmaternalwellbeing.com. I am so grateful for all of our panelists today and my co-host and those that are helping behind the scenes. And we're really, really excited. As part of our work, we were really, really concerned about the proposed NICE guidelines, particularly for those who were from BME backgrounds who were going to be affected by this in a way that we saw that could really wasn't a solution into the poor outcomes, but actually could potentially make things worse. Based on what people are saying and what we hear people talking about their maternal experiences, we really felt that this needed to have a further look. But we also thought that this was an opportunity that we could help educate a lot of people around, what physiological birth is, and how inductions are often offered, what they need to consider when they are offered an induction, and just give a bit more conversation around inductions and their place in maternity care. So I'm going to hand you over to my co-host, Agnes. She's going to introduce herself and the rest of the panel. Agnes.
Great, so hi everybody, and what a good turnout for this evening. Myself, I just had to try and put the kids to sleep a little bit earlier because we don't want any of that. But just to quickly introduce myself, so my name's Agnes Ajipong. I'm the head of engagement for a national charity called Best Beginnings. And Best Beginnings is a charity that exists to reduce inequalities in the early years, particularly looking at pregnancy up until the age of 5. And we do this for a number of different ways, but most notably, or what most people know us for, is our award-winning Baby Buddy app. And we've just launched Baby Buddy 2.0, which is the first pregnancy and baby app that not only has daily information for mothers, but also for fathers as well, that is designed and done by dads, for dads. So please do download Baby Buddy 2.0 if you haven't already. But back onto the subject matter of this webinar, this is so important in terms of the conversation that we're having here today, that we're having around induction of labor, the NICE guidelines. And for me, I'm so privileged and honored to be with a panelist of Black and brown women centering and leading on this topic. And I feel personally that for too long, usually these topics are done to us as a community, and we're usually kind of bystanders. So to actually be co-hosting, this panel, I'm honored, and I'm so looking forward to hearing from you all and the conversations that are going to come as a result of the topics that we're discussing today. So I'm not going to do the introductions. I'm going to pass over now to Dr. Cheryl Perry. Please, could you introduce yourself?
Hi, I'm glad to be here, and thank you to Natasha for inviting me to be part of this panel. I feel very humbled to be working with such a lot of experienced individuals in this field. So as I said, my name is Cheryl Perry. I'm a clinical pharmacologist and a regulatory affairs professional with over 20 years experience in the pharmaceutical industry. I'm also one of the directors for the Women's Health initiative that Natasha has started. And most importantly, I'm a mother as well who has experience of induction of labor. So hopefully, you know, some of these, I'm here to learn as well as to share with you as well this evening. And my role here is maybe to talk about some of the drugs involved in the induction of labor as well as used in pain management.
Thank you, Cheryl.
Thank you. And could we go over to Anna now?
Marley.
Sorry, Marley.
Oh, that's okay. Hi, everybody. You can hear me, can't you?
Yes.
Yeah, so my name is Marley and I am a midwife. I've worked as a midwife for almost 13 years now, in all areas of maternity. So I've worked in hospitals, I've worked in birth centres, I've worked with women in their homes, I've worked in the NHS and in the private sectors. So I've had quite a bit of experience with people through their pregnancies, their birth and postnatally. I don't work in the NHS anymore. I spent 11 years working in the NHS before deciding to go out off and do different things, and working more in the private sector now. So I'm also a mother of 5 children, had a wide range of experiences myself with pregnancy and birth. But what I do now is a lot of speaking, a lot of teaching. So I teach people online and in person about basically achieving the best birth possible for them. And for most people, they want to have an uncomplicated pregnancy and birth, as straightforward as possible with as little intervention as possible. So I just try to help people achieve that through education, informing people with as much evidence as possible. And like everybody else here today, we just need to have this discussion to basically try and understand, you know, what's going on with the guidelines, but also to inform people of the physiological birth process and also induction of labour. So yes, I'm looking forward to it.
Great. Sorry, Natasha, would you like to?
Yep, that's fine. So today's series and the next few days, it is for everybody. We obviously are going to be providing nuances of the kind of Black experience. We're not talking for all Black people. We're going to be speaking for our own lived experience. I also have lived experience of induction of labour. Also have had 3 children, and the other 2 births were not, I didn't have an induction. So we are going to speak with nuance. So this is for anybody at the moment who is expecting or planning a pregnancy, knows someone who's pregnant and wants to provide some support, healthcare professionals. I hope that we share insights that are going to be helpful to you today, and things that you can think about in your own practice, being reflexive and ensuring that you're delivering care that's really considerate, particularly not just about this proposed guideline coming in and being offered earlier for specific groups of people, which includes those who were aged over 35 with a high BMI, I think it was over 30 kilograms, those with assisted conception as well. So those were some of the people who were who this new proposed guideline was also targeted at. But I just hope that this is something that is really informative. So I have a question to kind of kick us off, and Marley, Cheryl, Agnes, unmute yourself so that we can all kind of chip into this conversation. This is a gathering style, so there's going to be lots of back and forth. It is not a formal meeting. Please ask questions if there's something that's not clear to you. Pop it in the chat or the Q&A, and we'll do our best to address any questions. So if there's any language that we're using that you think, oh, what does that mean, then please let us know in the chat if that's a language that's difficult and if we're talking too fast, because sometimes we get a bit carried away. So let us know if it's hard for you to understand what we're saying. So my first question, Marley, is could you kind of setting the context for this conversation, could you briefly explain what is an induction of labour and what's this idea of physiological birth? Like, what does physiological even mean? So can you just kind of simplify the two elements for us, and then kind of just take it away and help us to understand, you know, the low risk, normal kind of trajectory of how pregnancy and labour goes?
Yeah, well, I think it's probably best if I start talking about physiological birth, and then we can go into induction afterwards. So, but before I get into that, I think the main thing is to acknowledge that what everybody does want, I'm hoping, is to have a positive and safe experience, regardless of how that looks, regardless of whether that's a physiological birth or an induction or an assisted birth or whatever. But the majority of people are capable of having a physiological birth, which is a spontaneous birth, spontaneous labour that occurs with little to no intervention at all from the outside. And we know that the population, especially in the UK and some other countries as well, we are getting more and more complex. You know, we are seeing more health issues. We are having babies a bit later in life. You know, we're seeing more people who are coming in with things like diabetes and other conditions too. So saying all that, we still want to keep people as normal as possible. And we refer to these terms low risk and high risk. Now, I prefer to use uncomplicated and you know, uncomplicated pregnancies and complicated pregnancy, because I think some people can get a bit scared with the, you know, by using the terms low risk and high, or high risk in particular.
High risk, yeah.
Yeah, because when you say high risk, I think for a lot of people that automatically means, oh my gosh, you know, I'm going to have interventions, you know, I'm more likely to have poor outcomes, when actually there's such a vast kind of, what's the word, range. So you could have someone that's put in the high risk box that is put there because they are 40 years old, for example, but they're fit and healthy. You know, there's nothing else, there's no other factors, they're just their age. And then you have somebody else who has a serious heart condition, or who has severe epilepsy, but they are a lot younger. Now that person is also high risk, okay, but that person is probably more likely to have complications than the person who is 40. So that's why I prefer to not use the term high risk and low risk. But yeah, let's get back to physiological birth. So if you reach the end of your gestational period, whatever that could be 37 weeks, that could be 40 weeks, that could be 41 weeks. I've actually got a client at the moment who I'm looking after who is, I think, what day is it today? It's Monday, isn't it?
Yeah.
She is 43 weeks tomorrow.
Oh,
She's 43 weeks tomorrow because she's decided she doesn't want to have an induction. She wants to just wait for the natural course of her gestational period and wait for the baby to come when the baby wants to come, and which is totally her choice. So the body will go into labour when it's ready, and we're not sure what actually signals labour. There's lots of theories that go around. One theory is that when the baby's lungs become mature, they release some sort of enzyme and that kicks off labour. Another theory is that it comes from the mother. It's to do with the mother's hormones in the pituitary gland in the brain. So, but we don't really know. We don't really know what causes labour and why some women are pregnant longer than others. What we do know is that the gestational period does vary amongst different ethnicities. We know that very, very slightly, but that's still not necessarily a reason to routinely offer induction to specific groups of people, especially if there isn't any other reason to offer induction. So they're not classed as a high risk or having a complicated pregnancy. So in a nutshell, physiological birth is just one that occurs on its own from beginning to end. If there are interventions such as an induction, that's not a physiological birth. If there are interventions such as an epidural, that's not classed as a physiological birth either. So anything that could potentially change the course of the birth is not physiological. So leading on to an induction of labour. So an induction of labour is something that most people probably know what it actually means, is to induce the labour, make the labour happen for a number of reasons. Now, in the UK, most inductions of labour are done for either medical reasons, so the risks of the baby staying inside the womb are higher than the risks of the induction, and we'll go on to talk about risks of induction in a little bit. Or it could be that the pregnancy has gone on beyond 41 weeks. Now, years ago, when I trained as a midwife, we used to recommend, induction was recommended at 14, I think it was like 10 to 14 days past the due date. The NICE guidelines recently changed, and now it's 41, between 41, well, about 41 weeks gestation. So it's kind of getting earlier and earlier and earlier. And we know that not all babies and not all women are ready at that stage. The due date isn't always accurate. Often women will know when they conceived. They will know when they conceived, but they will go along to an ultrasound scan, which will give them a completely different date, often out by 5 days, 6 days, 7 days. And they're left thinking, hang on a minute, but I know when I conceived, so that's not quite right. And then what happens is that they're often offered an induction potentially earlier than 40 weeks because of their, because of the due date they've been given via the ultrasound scan. So an induction can happen in a number of ways. There's not just one way to induce a labour, but often what happens is somebody will go into hospital at whatever gestation. It could be prior to 40 weeks, could be after 40 weeks, and they will have a vaginal examination to see if the cervix is doing anything. Now, sometimes if you are over 41 weeks, your body may be getting ready to go into labour anyway.
So might I ask you, just,
yeah, sorry, go on.
Like, so some people have never seen their cervix and are not quite sure what their cervix is and what it does. Could you just explain a little bit about the cervix as well?
The anatomy. Sure. Okay.
Where is it?
Yeah. I should have some diagrams, really, shouldn't I? I've actually, you know what? I've actually got a uterus somewhere, but I don't know where it is. It's in my office, hidden somewhere. So you have your uterus, which is like the balloon shape, and on the bottom of the uterus is like imagine a balloon. Okay, so imagine you've got the balloon, and then you've got the little bit at the end that you blow into. So imagine that is the cervix. Okay.
Can I just say something? In my 3 decades plus of living on Earth, that's the best explanation I've ever had for what a cervix actually is.
Do you know
like
what?
A balloon. I'm never going to look at the balloon again the same way.
Yeah.
I get it.
And do you know what? I made a video. I think it might be. I think it's on my Instagram page. I made a video explaining dilatation using a balloon. So I put a little ping pong ball inside the balloon, and then squeeze the balloon. So I blew it up, and then the ping pong ball sort of sits at the bottom where the hole is, and then squeeze the balloon, and you can see the cervix. Well, cervix, not cervix, is it? But the bottom, the neck of the balloon changing shape as it kind of opens, that dilates and effaces. So the cervix is basically the little tube at the bottom of the uterus, and it's like a muscle. And throughout your life, when you're not pregnant, your cervix is closed, but there's a tiny little hole like that, and that's where you have that's how your period can come out. Tiny little hole, probably the size of like a pinhead, but they're still classed as a closed cervix. So you have your period through that hole. You get pregnant through there as well. That's where the sperm swims up. But during labour, that cervix, which is like a closed, long, probably about 3 centimeters long tube, starts to get softer, and it starts to shorten, and then it starts to open, to dilate. And that's how we, that's, you know, when we talk about dilatation, that's what we mean, because the cervix is shortening and it's starting to open. So an induction is basically forcing that to happen. It's making your cervix dilate if it hasn't already started. So if it hasn't already started dilating, then a drug is given, which Cheryl's going to go on to talk about in a bit, to what we call ripen the cervix, so to make it softer, to make it start to open up a little bit. And sometimes that drug on its own, which is called, it's like a prostaglandin hormone, is enough, or a synthetic prostaglandin hormone, is enough to kickstart a labour. For some people. For other people, it doesn't do anything, it doesn't work at all. So there's no guarantee that an induction will work, okay? Which is another common misconception. A lot of people think, oh, I have an induction, I'm going to be induced today and have the baby tomorrow, or have the baby later on tonight. It doesn't always work like that. Sometimes you get given the drugs for induction, doesn't work at all. And you can have, you know, 1 or 2 days of this.
Marley,
and yeah, sorry.
So you know, with the prostaglandin, and you said like with they'll check the cervix. Does that apply to kind of like most people who are maybe at the beginning of labour, or does it vary depending on your cervix, like what you're going to be offered? So is there ever a time where they're like, okay, this is not a cervix that we would like to give a prostaglandin to, and they will offer something different? Absolutely,
which is why I said there's different ways of inducing people. So if you've agreed to an induction of labour and you go into hospital, for them to decide the best way to induce you, there is no alternative but to do a vaginal examination and check your cervix. You know, they can't start an induction without doing that. You have to, otherwise we don't know what we're working with. So, and obviously if you decline a vaginal examination, that's totally up to you, but they won't be able to induce the labour without doing it. So if you have a vaginal examination and things have started to happen already, so perhaps your cervix has started to thin out a little bit, it started to efface, it started to dilate enough, then the prostaglandin hormone gel or pessary, a tablet, doesn't need to be given. So what would then happen is that they would just break your waters instead. So if the cervix is like dilated a couple of centimeters, for example, they're like, well, hang on, you know, her body's starting to do something. So let's go on to the next step, which is to break the rupture the sac of waters that's holding the baby in there. Yeah. And what that does is rupturing the membranes, that stirs up some of the hormones anyway, that kind of, you know, is supposed to help get things going. And that can be enough to get the labour going. Okay. One of the, I've had 3 inductions. So one of my inductions, that's what happened. I literally just had my waters broken, kick-started labour. And that was enough, didn't need anything else. So that's the second stage. Now, again, you may well have a situation where you've had the prostaglandin, it's worked, it's dilated the cervix a little bit, great. Let's move on to stage 2, rupturing the membranes. And then nothing happens after that. So if nothing happens, then the third stage, and the final stage, is to put a drip of a synthetic hormone called it's a synthetic oxytocin hormone. It comes, depends where you're from. In the UK we call it syntocinon, in the US it's called Pitocin, and it just makes your uterus contract. And those are the 3 stages. So but you can't start the third stage, you can't just put up syntocinon on a closed cervix where the membranes haven't ruptured. Okay, you have to kind of go through the system. Does that make sense?
Yes. Yeah, no, it really does. And you've really given me, like I have 3 children. I haven't been induced, but I didn't even know some of the things that you're saying to me now. I'm like, well, how did I even like survive and have 3 labours? And I didn't know some of this, you know, information. So no, thank you so much. I wanted to touch on some points that you said a bit earlier on, so I'm going to take you back. And you said some women from different backgrounds are slightly, they kind of have slightly different gestational periods, right, than others. Could you elaborate on that a little bit? Because I think when you said that, it really caught my attention, because obviously it's on the back of, you know, some of these assumptions that some of the NICE guidelines, you know, have come about, and some of the conversations I've had around that. what are the different gestational periods?
Do you know what? I have tried to do as much research as I possibly can on my own about ethnicity and gestational periods, and there isn't enough. NICE have come up with some evidence from several years ago that suggests that Black women, now it says Black, but it's quite vague. It doesn't kind of say, well, you know, West African, East African, Caribbean, you know, what are we talking about here? In general have a lower, a shorter gestational period. So on average, I think 39 weeks and a few days than white women. But what's interesting is that, so I worked for many years in a hospital in London where we had a high population of East African women. And I remember, so way before any of this, you know, all this nice stuff came about, this is like years ago, I remember thinking to myself, all these women, all these East African women who come in, and I say East African, I'm specifically from Somalia and Sudan. So there was quite a high population of these women in that area. Most of them seem to go to 42 weeks and over. So when I heard from NICE that actually Black women as a whole give birth or have short gestational periods, for me, I thought, oh, does that include Black women from everywhere? I mean, what are we kind of referring to here? So it's quite difficult. There isn't enough research.
And I think that is such a good, like, when people think Africa, and I don't know if this is a Western lens, like Africa is so diverse. Like, I'm from Ghana, my kid's dad is from Tanzania, East Africa. So when you're talking about East, I was like, eagerly listening. Which part of East are you going to say?
Which is why I said, yeah.
And
can I just chime in here about the diversity? So we actually see this in like clinical trials. There's a bucketing of ethnicity. So when we're talking about medication, they will say in Black is always Black versus Caucasian. And I always say, what do you mean by Black? Black is so broad, because when they say Black, they encompass mixed race, they encompass, you know, people from South America, if they identify as Black, or if they're from Africa, if they're from, you know, it's such a broad thing, and there is diversity, you know, and you can find, you'll get geographical isolation. So you have pools of people who've lived it, you know, they're from a certain region and they may behave differently during pregnancy than someone who's from a different region. And that's called.
And why do you think that is? Like, is it lazy reporting? And I say that because we're living in one of my guilty habits, and I'm going to own up here, is watching those ancestry.com announcements on YouTube, and people are like, I'm 10% this, and I'm, you know, and so, you know, we know, like, it's public knowledge out there that Africa in general is so diverse. Like, they're tracing people to Benin, to Togo, to Cameroon, like the diversity in terms of, you know, Africa. So when it comes to health and medical research, I'm kind of surprised then that it sounds a bit lazy. And anyone who's from a medical background, don't shoot me here. It just sounds a bit lazy, because when I watch those videos, it's very precise in terms of the diversity. But when it comes to us,
so that's you know, that's quite easy to explain, because Black people don't like to go into clinical trials. Okay, so when you have a situation where you have 90% of those who are entering clinical trials are Caucasian, and only maybe 10% or 5%, well, you'll see a trial and there's only one person who's Black. Well, there's a hesitancy amongst Black people to enter trials, and that's historic.
Yeah, I think. I think you're a very polite way of saying hesitancy. I think you're using very diplomatic ways. I'm not as diplomatic, so I think there's a lack of trust because, you know, previous injustices that have happened to Black and brown people, within medical research.
But the things that sometimes I don't think we're thinking logically. So if you have a trial where predominantly a whole bunch of Caucasian people are entering this trial, then it's not really targeted at a race, right? So they're not. Why would you then? Yeah.
I agree.
And it's so I feel that we're doing ourselves a disservice by not considering entering so, because we don't have sufficient data actually on a lot of things, whether it's maybe even pregnancy, whether it's we look at the clinical trials all about COVID, and we see predominantly the hesitancy is amongst Black and brown people, right? Okay. And the majority of, but we're not going to go down that rabbit hole.
We're going to go down that rabbit hole on day 3. So day 3, we're going to be exploring that. But I actually did want to just kind of make a comment just to add to this, and then we're going to come back to birth. So, we hear about hesitancy, and I just want to throw something else out there, that there's also like, there's a multiplicity of reasons why people don't participate. And I see this even amongst white British people. And that's also people's ideas about health and life and living, and their data. So I think that sometimes, like, yes, there's like hesitancy and trust issues, but I also think that sometimes sometimes it's not just one reason, and sometimes it's not just the trust and hesitancy. Sometimes it's like, well, who benefits? Like they might not feel that there's a good trade-off for giving up their information and personal data to how they're actually going to benefit from a particular trial or study, research paper, and the findings. And we've seen this with things that have done before, that they feel that they're researched and then nothing comes off the research. Yeah. So I think that it's really important to make sure that we kind of think a little bit more broadly
that's about across the board, though. That's across the board.
Right, this is what I'm saying. And so if you have a smaller population of Black and brown people in a country like the UK, then obviously that's going to be, they're disproportionately like underrepresented in a research paper or whatever. And then, people need to go to the greater effort to include those people as well.
But they're trying to do that now, I think.
Now?
Because it's really quite challenging to actually get a representative population. So for instance, if you're researching a particular drug and you want to have it approved in the US, you have to show that your drug has been studied in a representative population. Now, the problem with that is that Black people only make up 13% of the US population. So if you have a clinical trial that only contains 100 people, then how many Black folk are in that trial? They have to recruit, not many, right? And it's not really enough to make any conclusion really about that drug in that subpopulation. So you actually need more data. You need to pull the data. So actually depending on the indication, a lot of these trials, especially the late stage trials, they tend to be, they're global trials. So they're collecting data across ethnicities in many different countries.
Things like this, though, I mean, like talking about gestational period and ethnicity, it's actually a lot easier for the researchers to gather the information, because it should be easier.
It should be, yeah.
Because when you go to hospital, when you go to see your midwife and you have your booking appointment, they ask you lots of different questions. They ask you about your heritage, and all that information goes onto a computer system. And then when you give birth, the gestation you gave birth goes onto the computer system, and then all that information goes off, and the stats are just pulled from that. But the problem is people aren't entering ethnicity correctly. I went to the doctors recently, and I got asked to check my records, and I've been put down as white for 40 years. And I've told them numerous times, can you change that? Because that's not what I am. I looked on my daughter's medical records once, and her ethnicity was was completely wrong. They put her down as Black African, when I hadn't told them that's what she was. Someone had just looked at her and just assumed and just jotted it down. So the problem is either information's getting added incorrectly, or perhaps people aren't offering what their ethnicity is. But to be honest, the information could be pulled off pretty easily, you know.
Yeah. But not all the systems talk to each other. But I think this is the problem, depending on the health authority and so forth. They don't all sing together, right? And I think this is some of the problem. And I think information is missed because it's also reporting of side effects or whatever that are observed in that woman when they're in labor, because to be fair, it's actually quite difficult. You know, it takes a long time to actually fill out a yellow card or something and report everything you see that happens to a woman. And I think there's a lot of under-reporting of what's happening during labor or when a woman's receiving these medications. It may go on her file, but it may not get reported. The pharmacovigilance is just not there. And really it should go back to the companies, because you know they actually collect the data that's reported, and they
Cheryl,
do.
So while you're speaking, so I have a question, 2 parts. So you was talking about, Marley, like high risk and low risk, and one of the reasons that I believe that the kind of proposed guidelines had a strong reaction was because people felt that it may negatively impact people's experiences. Could you just kind of elaborate on, you know, like how you had your experiences of IOL and how people can have a positive experience of IOL, or just things that they can do to be as safe as possible if they are considering it or they need to consider it. And then Cheryl, I'd like to kind of hear you speak about the kind of medication side of things as well. So Marley, if you could kind of go into that for us very quickly, and then hand over to Cheryl for the kind of medicine side of things.
Okay, so who's going first here?
Marley, go first.
So what do you want me to talk about first?
So positive induction experiences. Kind of, I want to really hear about your lived experience of IOL, and what people kind of can expect and what they can do, because you had a positive experience. I didn't have a good experience.
And I think it's very important to remember that everybody, whether you have a physiological birth or an induction or a cesarean or whatever, everybody's experience is totally different, and all you can do is, you know, whatever you decide, as long as you make an informed decision, all you can do is to try to have the best experience you possibly can. And I think the main thing that helped me with my first induction was the person that was actually looking after me, and the environment that she kind of set up for me. And I can see that now in hindsight. So the midwife that I had at the time, I had a midwife and a student midwife. I was only 18 years old. This was a long time ago, and very, very, they were very, very patient, you know. So when they gave the first dose of the prostaglandin, they're happy just to wait. And then I did go into labor. I didn't need anything else. That kind of set me off into labor. And when that set me off into labor, they just left me just to, you know, labor as if I'd gone into labor spontaneously. And they didn't dim the lights down. Everything was very, very calm. So one of the things I would suggest is there is ways that you can make an induction as home from home as possible. You can still have your music playlist. You can still practice your hypnobirthing. You can still have your pillows and dim the lights down. You know, just because you're having an intervention doesn't necessarily mean that everything's got to be, you know, bright lights, highly medicalized, people rushing in and out of the room, machines beeping really loudly. Because if you keep your adrenaline levels down, that can help with the whole process, really, because we know that fear can create tension and pain.
Slow down labor.
Yeah, and slow down labor. And
so would you say that then in that case that there's also a responsibility for staff to create environments that are favourable to, I guess, helping people to have a successful induction experience, if that's the road that they want to go down. Like they need to recognize their role in women's experiences and birth people's experiences of inductions.
Absolutely, absolutely. And even when you've had an induction, when the process starts, any interventions that come after that should be the woman's choice, whether she wants to have an epidural or whether she wants to have whatever, she still gets a choice. I would always say ask lots of questions, and if you've decided to be induced and you've written a birth plan or your birth preferences, update that to one that's based around your induction. Discuss things with your care provider and ask as many questions as you possibly can, but you can still do things to try and keep the experience as positive as possible. All the things that we suggest that you do to try and aim for physiological birth, like keeping active, and there's certain positions that you can get yourself into.
Being upright.
Yeah, the Miles circuit, if anybody wants to look into that, that's quite a good one. And yeah, I mean, you don't have to necessarily be stuck down to the monitor, the fetal heart rate monitor, when the process is beginning. I mean, we do recommend it if you get to the point where you have to have the drip. We recommend you have the continuous monitor, but prior to that, you don't have to be sat on the bed the whole time.
So can women because I've had this question a lot, so women who have an induction, do they have to have continuous fetal monitoring, or can they have intermittent monitoring?
It's very unlikely that any healthcare professional is going to put an oxytocin drip in anyone's hand if they're not on a continuous monitor, because it's a synthetic hormone. It's not a real hormone, and it can cause very, very strong, it does cause very, very strong contractions, and not all babies tolerate it. Some babies are absolutely fine, and you can have a straightforward labour. Some babies don't. So it's recommended to have continuous monitoring when you have that drip in place. But you don't have to be strapped down. And you can ask if there's portable ones.
Okay, so they can have continuous monitoring but be mobile. And is there any? If it's so that's an important question for people to ask. So those that are watching ask that question to your healthcare provider. But also, are there any differences in outcomes? Do you know, are there differences in outcomes for people who are on continuous versus those who are on intermittent? What are the differences in outcomes? Do you know? Are you aware of those differences?
Well, I know there's been some research that has shown that people who are on continuous monitors are more likely to end up going off to have a emergency birth, that when the baby's born, the baby's is absolutely fine, because things happen in labour, and you have to be skilled at interpreting a CTG, so that's the monitor, the fetal heart trace, and sometimes things happen in labour. The baby can grab hold of the cord or put a bit of pressure on it, and the heart rate drops for a bit. And unless you're experienced identifying that and what it means, I think you're more inclined to be rushed off for an emergency birth if you're on a continuous monitor than if you're not, even if the baby's actually okay. It's a bit of an insurance thing, rather be safe than sorry. Do you know what I mean? But other than that, no. I mean, I think that it does help for those births where you've got oxytocin in play, and it's causing too many contractions. So we can see them, we can see that she's having too many in 10 minutes. And alongside kind of standing there counting them with her, you can see them on the trace. So in which case you might stop the infusion of the oxytocin. So they are helpful, and I think in a situation where you've got the oxytocin drip running, then I think it is important to have the baby monitored, and have the woman monitored as well, because if you have too many contractions, that can cause issues for the mum and as well, not just the baby. So
it's really important for people to know that they but they might expect that a healthcare professional is going to say to them, if you're on the drip, then this is what we do or need to do, that they need to expect to have that conversation and discuss, what they're going to do going forward.
Yeah, I mean,
obviously, I'm assuming that there's people who refuse to have that.
Yeah, I mean, at the end of the day, if somebody says they don't want to be continuously monitored, then that's absolutely their right. But for safety, a healthcare professional may say, well, we can't start the drip. I'm not prepared to put you on that drip unless we are monitoring, because we're not talking about physiological birth anymore. We're not talking about the body's natural process. If you are, if everything's happening naturally, then there shouldn't be any reason, unless there's an indication, to offer a continuous monitor. But if we are intervening, and this is what we call the cascade of intervention. You start one intervention, then you end up with another. So you start an induction of labor, then the next intervention would be a continuous monitor. Potentially the next one could be an epidural, because induction can cause more painful contractions. So, and then we know that an epidural has a high risk of instrumental birth. So you're more likely to end up having a forceps birth. So that's what we call the cascade of intervention. And it's important that people understand that one intervention often, not always, but often leads on to more. But this is why we need to be having these conversations, and people who are having babies need to be having these conversations with their care providers as well.
Yeah, and if you can't have that conversation for whatever reason, seek a doula, seek a local birth support group or birth charity. There's AIMS and there's also Birthrights. So I want to come on to Cheryl. Thank you, Marley. You've done a brilliant explanation.
Welcome.
I'll go on Agnes and then we'll go on to Cheryl.
Yeah, no, this is to Cheryl actually.
Oh, okay, go ahead.
Marley, you explained so many different drugs. And just from a layman's, like you're talking about like synthetic hormones, and Cheryl, I know this is your kind of key area when we're talking about like drugs. And so first of all, what is a synthetic hormone for beginners? Okay,
synthetic hormone is one that's made in the lab, basically. Okay, so it's not taken from the body. So for instance, the body produces oxytocin naturally. So and when you breastfeed, you produce oxytocin. The contractions are stimulated by oxytocin and so forth. So in the case of induction of labor, you want to stimulate what is not happening naturally. And so they give something that is a similar, we call it a similar, it's similar to, because it's a protein. So if it were like a chemical, if it were a chemical drug, so like paracetamol is a chemical drug, okay? Whilst a hormone is usually a protein, and usually we call them similars as opposed to generics, okay? So we know what a generic drug is. So, pardon?
Oh, no, so I thought you was ending it. I want to know, are all synthetic hormones the same? So like if you went into one hospital and you was induced, would that be the same?
Okay, so the so how do you pronounce it? Syntocin, right, that used for oxytocin, which is a synthetic oxytocin. That's a brand name, okay? And it seems to be the brand name that's used across the NHS. Am I correct? You tell me. I think we have midwives. So that means it's coming from a specific manufacturer. Okay, so it's basically going to be the same. So if you have Syntocin in one hospital and you have in another, it's going to be the same. And where the difference is if they have different manufacturing sites. So if it's coming from Europe or UK, then sometimes you have some differences, but not enough. But it's essentially the same, because it's the same company that we're using across the UK, it appears.
Okay. Mm-hmm. So there can't be any, I think probably what I was trying to get at, but I think you've explained that properly. You're not going to get different outcomes for your induction experience based on different hospitals if you give birth in the UK.
Well, actually, the different outcomes are based on the individuals you meet. Yes, so we're discussing.
If you have a hormone I'm just
Yeah.
thinking.
So if you have, so if you have the same dose in hospital A as in hospital B, you should have the same outcome. The difference will be the environment.
Environment, okay.
Which includes the medical professionals that you come in contact with.
Okay.
So Cheryl, could you walk us through?
And the co-meds as well.
Yes. So Cheryl, could you explain some of this and how like the body processes these drugs, how they kind of impact the body, and the, I guess, success of IOL? I remember speaking to you, and I find your experience really interesting about being able to kind of vocalize that like the dose was too high, and actually having your midwife listen to you turn down the dose. So I felt that there was in that example too, these elements that we're talking about, the care, the listening, but then also you having that awareness that this is too much for my body. So I wonder if you could speak a little bit about the drugs and your experience as well.
Okay. All right. So I remember the first time I was used the term high risk, and also I was called geriatric, right? Okay. Because I was over a certain age, right? So I was called old. So language is really important. So I remember going to that appointment and told, okay, you're geriatric, you're high risk. Plus I had an underlying health condition. I have an autoimmune condition. So I was on drugs. And when I was told I was pregnant, I actually thought I was having a relapse. Well, I was having a relapse of my health condition, and I needed some steroids. So I said, come, I need some anti-inflammatories. And I had this GP registrar. And the thing, if you've ever been to a GP registrar, they give them, you spend twice as long with them as you normally GP. So they give you like a 30-minute slot as opposed to your 10, 15 minute. And he asked all kinds of questions. And he goes, could you be pregnant? I said, not a chance, I'm sick. And then he said, okay, we'll take a sample. And he said, oh, you're pregnant. I said, really? But I said, but I'm sick. Okay. And so this was interesting. So I then went for the first trimester, taking steroids. And I was on a number of medications, and at the same time, so that meant I was dealt with differently to someone. So maybe this would be considered a complicated pregnancy, Marley. But otherwise, I was healthy, right? So once I went past the first trimester, because many women don't realize that if you have an underlying health condition, especially autoimmune, that when you become pregnant, the hormones can actually just upset everything. So it can disturb, even if your condition is stable, it destabilizes. And so this kind of happened to me. And as a result, they just scheduled more scans than normal, just to make sure that the baby was okay. And also they treated me and not the child. Okay, because the thing is, because I had a condition that was, I have inflammatory bowel disease, which means that I don't absorb nutrients in the same way. So especially when the disease is active, if I'm not well, then there's no way that the fetus is going to thrive. Okay. And so I had to take maybe medication that others would like, oh, that's toxic, but I had to survive for the fetus, the baby, to survive. And so how I was dealt with was a little differently. And then also I heard about NCT, National Childbirth Trust. Is it childbirth? Okay. And in the town I was, I have to say, there's not much diversity in the town I kind of lived in. So that was kind of interesting, because at the time it was kind of a middle class town, and it seemed like everyone did NCT. And it's private antenatal classes, which aren't that cheap, but it was worthwhile. So it was over 6 weeks. And throughout the instructor, she was a biology graduate. So she was a science graduate, which probably made my experience of NCT maybe better than some others, because she really understood the medications and so forth. And so when it came time for labor and everything, I knew what to expect, because I'd heard about all the medication. I heard about what my options were. And it's to some extent empowered me to make decisions for myself. The other very influential person in my life at that time was my mother. My mother was used to be a midwife in Jamaica. and she was a health visitor, and that really helped because my mother, you know, she'd already also given birth to 4 children, and she basically said she taught me how to cope with the pain. So when I did have went into labor. Go ahead.
Just as we get into that point, is induction of labor then increased if you have a pre-existing condition? Because I know you've spoken a lot about, obviously you did have a pre-existing condition. Did that increase your risk?
Okay, so let me explain what happened. So basically my waters broke prematurely, but I didn't have contractions. So I literally went to the allotment. It was a funny story. My husband said, bring me some food. I took him some food and then waters broke. So I blame him. I called the hospital and I said, I think my waters are broke. And they said, okay, come in. And they did the exam, which is very uncomfortable, by the way. I don't want to scare anyone, but it's not that comfortable. And they said, okay, they have broken, and they did the sweep and all that kind of stuff. And they said, come back the next day. And they said, if it hasn't started naturally, then we'll give you a prostaglandin and so forth. And it didn't come. And it was 37 weeks approximately, and just no contractions. This baby did not want to come out. And it was interesting that I spoke with an Irish midwife, and she said to me, in Ireland, this is how we would have dealt with it. But the protocols in the UK are actually quite different.
And how was that? What did she mean by that?
She said that in Ireland, she said that they would have just given me some antibiotics and watched me for the next few weeks.
Okay.
They wouldn't have tried to induce labor. So, which I found quite interesting. And so the next day, so waters broke Sunday, Monday I came back, and they basically said to me, oh, you know, you are not leaving here without a baby. You're basically going to stay here until this baby is born, which was quite interesting. So I didn't think anything about it. It's not until I actually was researching for this webinar that I thought, actually, maybe I could have asked a few more questions about this. But I wasn't fully aware that at that point I could have asked. And they gave me the prostaglandin. But again, this baby, no contractions, absolutely no contractions. So it was Wayne the night. And they basically said, there's no point. We're not going to try it again. We're just going to induce you now. And I had a very good midwife, and she was a much older lady. She probably was closer to retirement than the start of her career. And she was excellent. She allowed me to she listened to me. When I said I didn't want to be examined, she said, okay, that's fine. And she allowed me to listen to my body, and which was interesting. So when I started pushing, she said, why are you pushing? What do you feel? Is it this sensation? She allowed me to take any position I wanted on the bed. There was nothing forced. And one thing NCT did help was make the husband useful. So when I was in a position where I couldn't actually make a decision for myself because the contractions were too close, he was able to make the decisions for me. So I just went through it, just gas and air. And then his doctor comes in and says, oh, you don't need to, we can give you something. And the midwife was like, no, you're doing really well. And she kept me calm. Plus I had my mother in my head, you know, as you do. I could hear her telling me what I needed to do to keep calm, to ensure that this labor happened in a speedy way. Plus she's old fashioned. She was like, you don't need to scream. It's not necessary. She goes, just let it wash over. She was like, just let it wash over you. And actually, that was the best. Actually, it was a very good advice, because by the time I was saying, give me something, it was too late. This baby was coming, and he came very quickly from 3 centimeters, 2 hours.
One of the key points, because we're about to go into question time now, that I've taken from you, Dr. Cheryl, and also from Marley, is you've both stressed upon the environment and the good midwife and the person. And I think that's the commonality. Both of your stories are completely different. You know, Marley, you talking about, you know, your pregnancy as a teenage mom at that stage at 18 years old. Cheryl, you know, your experience with, you know, an autoimmune condition at the time, and managing that and so forth. And what's really come come across to me as someone who's never had an induction, you know, I was kind of new to this induction world, you know, until a couple of months ago, is how much the environment, because I actually thought, you know, coming into this, actually it was the drug. As soon as you have the drug, it's going to be more painful, and that's it. But I can really hear, you know, like coming across, the environment plays so much of a great role. Having that midwife and of that calming environment, and that person to kind of really bring you down.
Yeah, I don't think the pain goes away. It's how you deal with the pain.
Labor is different. Yeah.
It's different.
Yeah.
Okay,
It's labor.
So the pain is still there, and I have to say the pain was an interesting pain because it was like outside of my body pain.
Yeah.
So, but I was able, when I realized I couldn't take, I just told her don't up the dose, because she was just upping the dose because I wasn't getting the contractions weren't coming and so forth. And when they did come, I was like, don't go any further. But I would like to touch on, so we don't actually miss this, is that we do, I think many people are concerned about the impact of these drugs on the baby, for instance. So I would, you know, especially I'd say the pain relief is probably more of a concern. That's probably the thing that's probably getting impact. So if you take something like pethidine, so you take the opioids, like basically there are only a few that are offered. So there's pethidine, there's diamorphine. Those will cross the placenta, okay? But
I love pethidine. That's why when you said that, I cried out for pethidine. So as soon as you said that, I'm like, I'm triggered. Okay, I'm listening.
Okay, so they will, and actually most drugs do cross the placenta, but it's just the rate at which they cross the placenta. So if something crosses the placenta very rapidly, then obviously the baby gets a higher dose, and if it's slowly, then obviously they get a lower dose. And so these things will, and so there's obviously some monitoring that's involved, and then it may make the baby a little bit more sleepy on delivery, and that's standard. And one thing, go ahead.
Sorry, so just kind of think about the guidelines, but also our survey that we did, where many women actually had the induction offered prior to the 39-week suggestion by NICE, which is one of the concerns. Actually, this is already happening for a lot of people. It's happening well before 39 weeks anyway, and that will only maybe increase how many people are having inductions that are not being supported in the way that yourself and Marley had that support. So in a younger maybe child that's of an earlier gestation, but also potentially smaller, does that have a greater impact? But do those drugs have a greater impact on babies who are at an earlier gestational age? Do you know?
Well, the rate at which drugs cross the placenta is dependent on the type of drug, the size of the placenta, and so forth. So there's certain factors, and so which will determine the dose they receive. Okay. And also how many doses you receive, right? So if your labor is particularly short, then obviously they're not going to receive a high dose, and it all depends on when you start to receive your pain relief. So that will determine the overall dose. And actually, many of these drugs, they kind of have what we call they don't have long effects, so you get them repeatedly. So I think it will depend on how young, and if they're really young, maybe, and you're going into labor very early, then maybe you're not going to be having an induction of labor, because it may be an emergency situation.
You was 37 weeks, so 37 to kind of 40, that's a long time, and potentially even later if you've gone on later.
Yeah, well, I was fortunate, I only had gas and air, so that wasn't really I didn't have the pethidine and so forth, so that wasn't an issue for me. But maybe Marley can speak more to this, because she would have seen a wider range, she'd have a wide range of experiences around much younger babies.
Yeah, I think babies that are 37 weeks plus, there's not really going to be much difference, really.
No.
Okay. And Cheryl, what about like some of the side effects like after? So on the mother, I remember when we spoke, you talked about like blood pressure, like any changes in blood pressure and things like that postpartum. So are there anything that we kind of need to be aware of and women might need to be quite mindful of as well when it comes to the after effects of IOL, or Marley, even, whoever can answer that question?
Firstly, I think the woman is so exhausted at the end of whatever procedure, whether it's natural or not, you're just tired, right? So so it's difficult to distinguish maybe sometimes whether it's actually the drugs or you're just exhausted from the labor. But it also depends on the underlying health condition of the woman, right? So if they are in good health, then it may be easier to spot if there's an issue so I'd say like things like pethidine, diamorphine, the standard side effects are you feel woozy, you feel dizzy, you may have nausea. Okay, those are the things. Gas and air, very short-lived. As soon as you stop the gas and air, you should feel fine. Epidurals, you know, you tend to be catheterized and so forth, and you can't feel if it's done properly and both legs are numbed and everything, then you know, you're not walking for a while. But the side effects, things can go wrong. Marley and I was sharing earlier, I don't know if you want to share some of what you have seen with epidurals that maybe are not maybe have been full, because not, I think sometimes we think that with epidurals it's like a full block, but you can have actually epidurals where women can actually walk around a bit and they can feel some of the contractions. So I suppose it depends on how much local anaesthesis gives. So maybe Marley, do you want to speak?
Anaesthetists have to go through all the risks of an epidural before they give it, which isn't always easy when somebody is in the throes of labour and they're not listening properly, because often the women that are asking for an epidural, you know, often they're either transitioning, so they're just approaching, you know, full dilatation, and they're not far from birth anyway, or they're ones that have been having this long, what we call prodromal labour, because perhaps the baby's in a bit of a funny position, back to back or something, and labour is just taking a long time. But for someone who's really uncomfortable and who's in a lot of pain, listening to an anaesthetist talking about the risks of, you know, you could potentially have a severe headache or nerve damage, or, you know, all these other things that aren't particularly common. Some, you know, like having numbness that goes on for several days. But these are things that you need to know, which is why it's best to do your research and be informed before you go into labour. Because if you are pregnant and you understand all the risks and the benefits of all different types of pain relief, then you can have an idea on what you want to focus on. So if you do think to yourself, actually, I don't really want to have an epidural, I'm gonna try to stick with gas and air, for example. But then you do get to a point in labour where you think, actually, I want one now, but you already know what the risks and the benefits are. So you don't, you know, the anaesthetist will come and talk to you and tell you what the risks and the risks are, but that's already kind of ingrained in your head anyway. And perhaps you may well have thought about other forms of pain relief. But there are certain risks, like I said, like headaches, and which is quite a common one. Nerve damage isn't so common, but it does happen to some people.
Okay, so maybe I can just say something in light of the NICE guidance. So although we focused in on maybe the early IOL for Black and brown women, that actually the NICE guidance actually have elaborated on the use of these drugs. And so they have become a bit more granular. And so I'm really overtly stating that the mother should be informed of all the risks. And I think I need to second what Marley is saying, that it's really difficult if you're in the throes of labor to actually take on board what these risks are. So it's really good. It's important that women attend antenatal classes, they ask their midwives ahead of time what the risks are, so that it's not just too much information that's coming at them when they're halfway through a contraction, say, when you can't really process what's going on and assess properly what's going on. But I think in these guidelines, they're trying to kind of address something maybe that was an issue beforehand. So they're really quite prescriptive that a woman should know exactly what the risks are for each of the options for induction of labor.
Thank you, Cheryl and Marley. I think now would be a really, really good time to take some questions. So I think Anna is going to share with us some questions and kind of facilitate this section of the webinar.
Hi, it's been so great listening in. There's been lots of conversations in the chat and some questions. So first of all, for everyone who's listening in, if you do have any questions, you can pop it into the chat, or you can use the Q&A function. Or if you want to be brave and come up to ask your questions directly to the panelists, and that's an option as well. One of the first things that popped up is actually for you, Natasha. Some people would like to know if there will be a certificate available for attending.
We didn't plan that in, but it's something I'll have a think about. But definitely we need to make sure that people attended all 3 days if they do want one. But that's not me committing to anything at this moment in time. But I'll have a think and look into it.
And before we kick off with the first question, I think some people wanted the panelists to put in maybe social media handles into the chat so that people can know where to follow you if you feel comfortable doing that. So that's something that came up earlier. And we have a question from, I hope I'm pronouncing your name correctly, Delia, who's asking Marley, what are your thoughts on Vbac mothers in the NHS? Did you have any experiences?
Yes, I had lots. I've looked after lots of women who have had Vbac. So if anybody who doesn't know, Vbac is a vaginal birth after a cesarean, and lots of success with it. I've had 2 Vbacs myself. So after having a vaginal birth, and then I had a cesarean section after that, and then I went on to have 2 further vaginal births after that. I had a water birth, and I was induced for them both. So you can do these things. People might say to you, you know, how could you be in a birthing pool with a drip in your hand after you've had a cesarean section? But you know, if you want something, then you can usually speak to whoever's looking after you, and you can have it. But yeah, most of the women who I've seen that have, you know, attempted to have a vaginal birth after a cesarean section have been very, very successful. But that success again is a lot higher when you've got a care provider who's facilitating that, who is kind of on your side and wants to help you achieve that.
Thank you. So this next question I'm going to aim at Cheryl. Can you, I think Semia is asking, can you explain the nitrous oxide as pain relief?
Okay, so the Entonox, which is 50% oxygen, 50% nitrous oxide, so it's not pure nitrous oxide. Yes, and it does cross the placenta, if that's the question that's really been asked. But it's kind of really short-lived. And I think it was funny, I was discussing this with Marley ahead of this, and we were just saying that actually why we don't feel that it doesn't really impact the baby is because actually towards the end of labor, you're not really likely to be able to coordinate the breathing very well with and the pushing and everything. So actually the dose that the baby would get is low, but there's little, the risk is very low with nitrous oxide. And one of the side effects is it can make you feel a little bit lightheaded and a little bit nauseous. But you need a level of coordination. I had gas in air, and I felt that I literally had to have my husband saying inhale at one point, because I couldn't do everything. So
I used gas in my labor as well, Cheryl, and I had to think, okay, inhale, exhale, inhale. So
I love gas and air.
So do I. It's great stuff.
I remember turning to my husband and saying, you should try some of this. It's amazing.
I only learned about how to use gas and air on my third birth, and I was like, this is gas and air, like what have I been missing out on? So there is a way and a technique to really breathe it in properly.
there is a
There
technique.
is, yeah.
I think it helps with the labor, because you are breathing deeply and it has a rhythm to it. So for me, I found it helpful. Well, we have another question from someone in the audience, and it seems more of like a personal story. It's from Mahmouda, who says, my consultant has advised I should be induced at 38 weeks. I have gestational diabetes, but my diabetes is currently controlled and baby is growing normally. I am 35 weeks pregnant. Can this advice of induction be changed, or is it induction at 38 weeks a definite? So that's open to anyone.
Yeah. You know, it's interesting because often the thresholds regarding blood glucose levels in pregnancy, they can vary a little bit from hospital to hospital. That's what I've noticed anyway. So somebody could have a blood glucose measurement in one hospital and be classed as diabetic, and somebody else somewhere else isn't, which is a bit difficult. But the guidelines, as far as I'm aware, unless they've recently been changed, suggest offering, and this is the key word, offering in an induction of labour to those women who are have been diagnosed with gestational diabetes and their diabetes is uncontrolled at a certain gestation, and I can't remember if it's 38 weeks, between 38 and 39 or something. But if it is well controlled, I think that goes up a little bit. I'm not sure if it's 39 or 40. I can't remember. So it's worthwhile having the. If you, it depends whether you're happy to be induced or not. I mean, if you would rather not, then it's worthwhile having that conversation with your consultant and saying, hey, you know, baby's measuring okay, baby's not measuring too big, and my blood glucose levels are okay, and everything appears okay. You know, can we perhaps revisit this at a later stage? You know, can we look at 39 weeks as long as, or 40 weeks, and see how it goes, just to give your body a bit more chance to go into labour. But it all just depends on how you feel about induction and how you're doing, you know, how well you are and how the baby's doing. The reason why the guidelines are there is because we know that with diabetes, type 1, type 2 gestational, we know that people who are diabetic, there is a slight increased risk of having a stillbirth as you get closer to your due date, which is why the offer is put there. But you know, you're well within your rights to have that open conversation. But just remember that just because something is suggested doesn't necessarily mean that you have to do it.
And I think that's a really important point to reinforce to both healthcare professionals and expectant parents, that offering is just that, it's supposed to be an offering, and we should be supporting people to make informed decisions. And I think that's so important, particularly if you are concerned about the care that you're going to receive by agreeing to an intervention. There's something that this question's made me think about, which is like the impact. So we hear high risk, or people have GD, or pregnancy-induced hypertension, and so forth, these things. Is there a real difference, Molly, in like outcomes in terms of like if you have an intervention versus those who don't have an intervention? Is there a huge difference, do you know, in the actual outcome, the birth outcome?
I think it depends on what the risk is, you know, what the pre-existing condition is, for example. You know, I guess if for example, okay, so if somebody has got severe preeclampsia, you know, they're borderline having, they'd have an eclamptic fit, perhaps, you know, if the labour is not induced soon, which can cause potential problems for mum and baby, and can even cause death in severe situations. So if someone's got severe preeclampsia and they're offered an induction, then, you know, you could probably say that the outcomes are going to be a lot more positive than if they didn't have the induction. But then if you've got somebody else, so perhaps someone who is still classed as high risk, but they're classed as high risk because, I don't know, let me think, the pregnancy is an IVF pregnancy, for example. I'm not sure what the data is on IVF, and I'm not sure why we put it into the high risk bracket. But I can imagine that the outcomes will probably be similar. Do you know what I mean? So it just depends on what the pre-existing condition is and what the risk is as to whether, you know, the outcomes are similar, better or worse.
Okay, so for me, one of the thoughts that I've had is that, you know, we have people will fall on like a scale, for example. So while somebody might have like raised blood pressure, somebody might have high blood pressure, the outcome is shouldn't be like, they shouldn't be kind of not coerced, but they shouldn't be forced into saying, okay, this induction is going to reduce your chances, because based on what we've heard, actually it's the care. So if you go ahead and give someone an induction but the care is not there, then potentially are we adding a risk into this situation, as opposed to actually really mitigating what we, you know, propose, not me, but what is proposed as a risk factor. So
yeah, so it's weighing up the risks and the benefits, isn't it? So if someone has got, I mean, like you mentioned blood pressure, so there's thresholds, you know, so there's like a mildly high, moderately high, and then severely high. And if you've got severely high blood pressure, and you're pregnant and you've got other symptoms as well, and your risk of you know, having a stroke is really, really, really high, that it's probably going to happen if we either don't get your blood pressure down under control, or at least try to with medication, or if that doesn't work, you know, induce the baby, then you know, at the end of the day, you need to tell those risks to the woman that you're looking after as a healthcare professional. If the blood pressure is low, you know, we probably wouldn't be offering induction anyway, but there's certain steps that you take. But I think for every intervention, we need to be explaining what the risks and the benefits are for that specific person and for her specific condition and case. People who've got diabetes, for example, again, they're all different. I mean, you have women that are type 1 diabetics, you have ones that are gestational, you have people who have got controlled diabetes and uncontrolled diabetes. So it has to be like a personalized assessment. We can't be sticking people into boxes and saying, well, you know, you've got this and we're going to do this, and you've got this and we're going to do that. Everyone has to be treated as an individual. So it's very hard to say without taking someone's personal situation before being able to make a judgment. But I do urge people to ask questions in terms of the exact risk, you know, rather than just the perceived risk. And what is the exact risk, you know, as in percentages? What is my chance of this happening if I don't have this intervention? Do you know what I mean? I think that's what we should be saying, you know, like with a Vbac. So the chance, so you have a cesarean section, you have a scar on your uterus that heals. The chance of the worry with going for a vaginal birth after a cesarean is that there's a chance that your uterus can rupture. Now that scares people, but then if I said to Rani, well, the actual risk is 0.05 I think 0.05, or it works out as 1 in 200. So 0.05% or 1 in 200. So there's actually 99.5% chance that you'll be fine. That sounds a lot better, doesn't it?
Yeah.
You know, so that's what we need to be doing. We need to be giving the exact risk of things potentially happening.
Thank you, Margaret. We've got two, just kind of aware of time, we have 2 more questions that I'll just read together, and then people can, jump in. So we have a question from Samia who says, can you please talk more about your experience of water birth? I'm not sure who, if Cheryl or Marley has personally experienced a water birth or maybe facilitated a water birth. You could speak on that. And then someone in the chat, Emma, has asked, if we know that induction is not likely to be successful to enable a vaginal non-intervention delivery when the cervix is not right, is requesting a Bishop's score assessment a beneficial first step when looking to agree or decline an induction?
Okay, what one shall I answer first? The one about water birth?
Water birth, and then we'll end on induction.
Okay. All right. Well, I'll answer the water birth question. That's a very, very quick one to answer. So I wanted a water birth, even though I was being induced, and I'd previously had a cesarean section, because I'd facilitated lots of water births, and the ones that I'd been at with other women, they were always, well, most of them were just fantastic, and the women seemed much calmer in the water. So I thought, yes, I want to do that. But I got in the pool too late, and I didn't like it. So I got in, went out, because my labours were very quick. They were like one hour. And I got in, and I was like, no, I want to get out. And the reason I wanted to get out was because the baby was coming. But for many people, water birth, or at least labouring in water, so you can labour in the water in a bath or something, can be really, really beneficial. But it's individual for everybody. So, and the other question was, if we know that induction is not likely to be successful to enable a vaginal non-intervention delivery when the cervix is not ripe, or the things we don't know. We don't know that induction is not likely to be successful, even if the cervix isn't ripe. There's no changes at all. Sorry, when I say ripe, it makes me think of like a banana or something. But when we when we see the cervix and there's no changes, you can give that prostaglandin, and it can change within a couple of hours. So we don't know if induction is going to be successful or not. You can't just tell that. What the Bishop score does, a Bishop score has to be done on everybody that's going for an induction. So it's not a case of requesting it, it's automatically done. You have a Bishop score prior to being induced. The Bishop score helps us determine what to give you, how to induce you. So if the Bishop score is like really low, then because the cervix is not doing anything, then we give you the prostaglandin gel pessary. If your Bishop score is a bit higher, so things are starting to happen, baby's coming down, cervix is starting to change, then we might be able to break your waters. And if it's so that tells us what to do with the cervix before we go on to giving the drip. If your waters are broken and your cervix has started to dilate, but there's not really any contractions, and that's called, then we do what's called an augmentation. So it kind of augments labour by popping the drip up. But a Bishop score is always done, but we write it down in the notes. But, you can always ask what it is.
And it's interesting that the new guidelines are more prescriptive. So they will say it actually says that Bishop score has to be done, and what the level that they're looking at. Because
it helps the healthcare professional determine what to do and how to induce your labour. Often we don't need the Bishop score. We can tell when we're doing a vaginal examination, right, she's going to need this or whatever. But it just helps us to document it and record it.
I've learned something. I've heard of the Bishop score, and maybe it's helpful for women and people who are giving birth to know what they're being judged against. So that's really helpful. Thank you. I think that concludes the questions that we have.
Thank you, Anna. Thank you. So I just want to say a big thank you to Marley, Cheryl, and our Princess Agnes for helping us out tonight and giving us a smooth running webinar. Thank you for all the information that you shared, Cheryl and Marley. We really appreciate it. I want to say thank you to everybody who attended this evening. I hope that particularly expectant parents that you have found this really helpful. We are going to try and make the recording available. It's a matter of how and when, but I really hope that for somebody that's considering, weighing up their options at the moment, that they feel a bit clearer, or at least know what questions that they want to ask their healthcare providers. So thank you all for your questions, your participation, and your contributions in the chat. And also I want to say a big thank you to our sponsors for helping us to get not only the webinar up and running, but also the report that Princess has kindly researched and written up for us as well, which will also be available later on in the month. So I just want to say thank you and good night to everybody. And I hope that those of you who are expecting, I'm wishing you the very, very best birth experience. Good night.
Right.
Good night. Thank you.